Hi everyone, my name is Victorie, and this is my presentation on type 2 diabetes mellitus education and prevention. Starting off, these are some of the committee members that have been crucial in this study. The first one is Dr. Heather Daring, DNP, who is the chair. Second reader is Dr. Rachel Davis, and thirdly is the community member, Fei Heng. Now the purpose for this study is to compare how educational discussion and information handouts on self-management of diet, exercise, and medication adherence improve fasting blood glucose and hemoglobin A1C in individuals with type 2 diabetes age 25 and older, compared to not having any educational information in the primary care setting, and how that affects the fasting blood glucose and hemoglobin A1C within 10 weeks. A little background. So the prevalence of type 2 diabetes is rising throughout the United States, and roughly about 422 million worldwide and 34.2 million in the United States. Now, preventing chronic disease has been linked to self-care behaviors such as sedentary lifestyles, medication, adherence or non-adherence, symptom management, unhealthy diets, and glucose monitoring. Now, providing patients with quality diabetes education is crucial. This is important because it helps patients to make healthy lifestyle modifications so that they can better manage their diabetes condition. Now, effectively controlling diabetes can help prevent serious complications associated with the disease. Some of these are cardiovascular disease, diabetes retinopathy, heart disease, stroke, blindness, kidney disease, peripheral neuropathy, and an increased risk for infections. Now, through education related to diabetes and education to diet, exercise, and medication adherence, patients can make meaningful lifestyle adjustments. Lifestyle modifications have shown to delay the onset of type 2 diabetes and prevent diabetes complications. Now, the American Diabetes Association recommends that at least 150 minutes per week of moderate to high intensity exercise 3 to 5 times a week for individuals with type 2 diabetes. And this is to prevent any complications related to diabetes in the future. Now, the significance of this study is to evaluate the effectiveness of type 2 diabetes education among patients. To do so, we need to assess the individual's knowledge and barriers to understanding and self-care deficits, such as cultural, social demographic, psychosocial factors, cost of medications, inadequate family support. And this is important because this helps facilitate and structure care to meet the patient's needs. It also helps to facilitate better communication and understanding between the patient and the provider. Additionally, it helps to provide high-quality care through education, demonstration, and offer feedback as necessary for patients. So through education, we can help prevent and lower fasting blood glucose levels in type 2 diabetes mellitus individuals, in addition to lowering their hemoglobin A1C. This also fosters a collaborative teamwork through education. By doing so, we're increasing the adherence to diabetes self-management behaviors in adults aged 25 and older in the outpatient settings, and to improve hemoglobin A1C and fasting blood glucose. Another significance is to increase awareness on the positive effects of diet, exercise, and medication adherence that has been shown to improve and lower fasting blood glucose and hemoglobin A1C. This is also important because it helps to increase patients' knowledge of type 2 diabetes and hopefully promote a better self-management of their conditions. Now, the review of literature. We did a comprehensive literature review based on 10 primary research articles, which supports improvement of hemoglobin A1C and fasting blood glucose through diet, exercise, and medication adherence interventions. Now, we found 3 themes that we identified through the 10 primary articles. The first theme is the elements influencing knowledge deficit of type 2 diabetes mellitus and its complications. And these are knowledge deficit, lack of education, low-income communities, and perception of disease. Now, the second one is the barriers to diabetes self-management. And these include socioeconomic background, cultural beliefs and practices, psychological and behavioral challenges, limited resources, perception of disease, and health literacy. Our third theme is the interventions, and these include education on diet, exercise, and medication adherence. So, by understanding these themes, we can help the patients learn to improve their health and quality of life by knowing what type 2 diabetes is and how that affects their body systems and how they can control it or reduce those numbers through educating them about diet, exercise, and medication adherence. Next is our theoretical framework. Now, we used the health promotion model, as this is a holistic approach to enhancing overall health by combining nursing and behavioral science perspectives to encourage and guide the health behaviors of the patients. This theory is comprised of 3 key components. The first component is the individual's unique characteristics and experiences, like behavior and personal factors, such as gender, age, social cultural status, psychological status. Now, our second theme is specific cognitive and emotional behaviors, such as perceived benefits and barriers to action, perceived self-efficacy, activity-related emotions, and interpersonal and situational influences. Our third component is behavior outcome competing demands and preferences. Now this looks into the commitment to plan of action for these patients. Now the health promotion model can help facilitate the promotion of healthy habits and improve health outcomes for individuals with type 2 diabetes through these three key components. Methods and design. This study is a quantitative exploratory design with a retrospective chart review to assess the intervention's effectiveness and statistical significance on type 2 diabetes mellitus. The study took place in a clinic in the Western Pacific region of the United States. Informed consents and HIPAA consents were obtained prior to the study. We followed the American Diabetes Association practice guidelines for this. Now, the project was implemented in collaboration with the clinic's provider and manager. This was a systematic data collection analysis at two different intervals. The first one was at the beginning when we started the study, and the second was at the end of the 10-week project. Now, education was given on diet, exercise, and medication adherence, along with information sheets on that first day. We also obtained pre and post surveys, and those were collected. And the pre and post hemoglobin A1C and fasting blood glucose were also obtained for comparison. Now the sample. The study sample and the results were analyzed and presented using descriptive statistics, allowing for a clear synthesis and interpretation of the findings. Our demographic data consisted of participants with type 2 diabetes who were asked by the clinic's primary care physician if they wanted to volunteer for the research based on the inclusion and exclusion criteria given to the clinic. Now, we must understand that all of these patients were done, the study was done solely through voluntary basis. And the patients were over the age of 25 with type 2 diabetes. We took the pre and post surveys. So these are patients that took the pre and post surveys already. We did not consider any gender or ethnic groups in this study. Data analysis. So to compare the differences between the two observed data distributions, the Kolmogorov-Smirnov test and the Shapiro-Wilk test were used to test the normality of the sample distribution against the theoretical distribution using a significance level of p equals 0.05. Now, the normality test was based on the pair t-test, with the assumption that certain variables, such as the pre and post values, followed a normal distribution. But after the test, we found that the test indicated that there was a violation of the assumption for the pair t-test. And because of that, a non-parametric test was performed using the Wilcoxon-signed rank test. Now, the Wilcoxon-signed rank test was utilized to evaluate the difference in the pre- and post-intervention scores on hemoglobin A1C, fasting blood glucose, weight, and BMI. And this helps to determine if there's any statistically significant changes between the pre- and post-data tests. Now this slide talks about the results. So if you see here, the first row is our biometric variables, where we have our pre- and post A1C, pre- and post blood glucose, our pre- and post weight, and our pre- and post BMI. And then at the very end of that column, you have our two-tail, which is the p-level. And the results of the Wilcoxon sign test showed that all p-values for the 4 comparisons exceeded 0.05. Specifically, the pre- and post A1C, because that had a p-value of 0.646, which was higher than the other ones. The pre- and post blood glucose was at 0.530. The pre- and post weight was 0.089, and the pre- and post BMI was 0.062. Now, looking at that, we go into the limitations of the study. And part of this is because we had a small sample size of 12 participants, which limit the generalizability of the findings. Additionally, the time constraints may have limited the depth of the research analysis. So instead of a 3-month study frame, it was shortened up to 10 weeks, which normally takes us 3 months to show any improvement in hemoglobin A1Cs. Another factor is we did not account for external factors that could affect the results, such as social economic variables. And additionally, the study relied on self-motivation, adherence to dietary, exercise, and medication compliance, and guidelines which may have varied among the participants. As we did not look into how well they comply with the activities that we gave them. Now, discussion. The results of the Wilcoxon signed rank test showed that while p-values for the 4 comparisons exceeded 0.05, specifically the pre- and post A1C with a p-value of 0.64. Pre- and post blood glucose was 0.530, pre- and post weight was 0.089, and pre- and post BMI was 0.062. And because they all exceeded 0.05, the null hypothesis was not rejected, which indicates that there's no statistically significant difference between the pre- and post tests for any measures. This also implies that we may not have sufficient evidence to support the alternative hypothesis, suggesting that diet, exercise, and medication compliance significantly impacts the outcomes. So it is important to note that failing to reject the null hypothesis does not imply that we accept it. However, despite the results of the study, many participants reported improved understanding of how to manage their diabetes and fasting blood sugars and how to lower their hemoglobin A1Cs. Now, the implications for practice. There is a need to educate patients about lifestyle changes, a need for continual reinforcement on the importance of diabetes health management, a better understanding of patients' social economic factors to better facilitate the patient's needs. Additionally, it's important to evaluate participants' social support systems, physical and psychological well-being, as this plays a crucial role in a patient's capacity to successfully implement dietary modifications, adhere to exercise regimens, and maintain medication schedules. It's also important to evaluate the patient's level of understanding, their behaviors, their specific fitness levels, individual preferences, and their psychological states, as this can provide us with valuable insights into their readiness for change and overall commitment to enhancing their health outcome. In conclusion, education on diet, exercise, and medication adherence on type 2 diabetes mellitus showed promising results in lowering fasting blood glucose and hemoglobin A1C. It's crucial to empower patients through education to make lifestyle changes to enhance quality of life. There is a need to implement a comprehensive educational program tailored for all individuals with type 2 diabetes to increase knowledge and compliance. Now, reinforcement through ongoing education to maintain compliance and lowering the risk of type 2 diabetes is crucial. Through education, we can empower clients with the knowledge and the benefits of exercise, diet, and medication adherence and lifestyle changes on diabetes and their overall health benefits. The rest of these are the references for the study. Thank you.